Hello, I'm Tom Powles. I'm an oncologist from London. I'm the director of Bart's Cancer Centre. I treat patients with urothelial and kidney cancer. The treatment of first-line urothelial cancer is evolving very quickly. Over the last 12 months, there's been a transformation in the treatment of first-line metastatic disease. Previously, we've been giving Gemcis and Gemcarbo, followed by maintenance of avelumab. There have been two recent trials, which I'm going to talk about in a second, both of which now appear in the ESMO and NCCN guidelines. The first is with enfortumab vedotin, which is an antibody drug conjugate targeting Nectin-4 with MMAE as a payload, and pembrolizumab. The second is with platinum-based chemotherapy and nivolumab, and both these studies have shown an overall survival benefit in the first-line metastatic setting. There have been two trials which have driven these changes. The first I'm going to talk about is the nivolumab trial. The reason I'm picking this study to talk about first is it builds on what we were doing previously. Essentially, in Checkmate 901, it's a big randomized phase 3 study. It's a study where patients who were randomized or received gems eligible for gemcitabine and cisplatin, those patients were randomized to Gemcis or Gemcis plus nivolumab, followed by maintenance nivolumab. The study had progression-free survival and also overall survival as endpoints, and this study hit both of those endpoints. The hazard ratio for PFS was 0.72, for OS was 0.78. It also showed that the combination of Gemcis plus nivolumab had higher response rates than Gemcis alone. The drugs were well tolerated. The nivolumab didn't cause an enormous increase in toxicity. And there was also a 20% CR rate, which I think is noteworthy. The EV302 study was different. Enfortumab vedotin is a Nectin-4 targeted ADC with MMAE as the payload. Pembrolizumab, obviously, a PD-1 inhibitor. And the combination of those two together had really promising phase 2 data in the frontline cisplatin ineligible space. In this study, the 302 study, enfortumab vedotin plus pembrolizumab was compared to Gemcis or Gemcarbo. The EV Pembro was continued until progression. Here we showed hazard ratios of less than 0.5 for progression-free and for overall survival. There were 30% CR rate and about a 70% response rate. These results to me look really transformative. In fact, I think most people agree with me that this is the new standard of care and supersedes everything that's gone before it. The factors to consider EVP in the first line setting, I don't think is based around efficacy. I think pretty much everyone feels that EVP has superseded what we were doing with platinum-based chemotherapy previously, and that includes the recent nivolumab data as well. The discussion around which patients can receive enfortumab vedotin and pembrolizumab, I think, is very important because we have historically been using platinum-based eligibility to decide which patients are able to get first-line systemic therapy for metastatic urothelial cancer. Enfortumab vedotin and pembrolizumab has a very distinct adverse event profile from platinum-based chemotherapy, and therefore we need to come up with new considerations for which patients are able to have therapy. I think it's fair to say that the two areas of toxicity which would be concerning at baseline would be existing significant peripheral neuropathy or poorly controlled diabetes. Both of those would be a problem because enfortumab vedotin is associated with a neuropathy and also can very rarely cause diabetes. So those are two issues. I think inevitably there are some absolute contraindications for pembrolizumab. Active autoimmune disease requiring anti-inflammatory therapy, immune suppressive therapy. So I think there are pembrolizumab contraindications. There are the general performance status issues, so multiple comorbidities, performance status 3. Those patients may not be fit enough as well. So those are the general considerations. I don't see that there would be more patients who are ineligible for EV Pembro than GemCis or GemCarbo. And actually, I think there is probably a big overlap between the two. But the previous issues around things like renal function are now less relevant for EV Pembro. So for those patients who are not able to have enfortumab vedotin and pembrolizumab, uh, then one needs to consider, what would we give those individuals? Um, the reality, I think, is the vast majority of patients who are eligible for platinum-based chemotherapy, GemCis or GemCarbo, are indeed eligible for EV Pembro. Perhaps a contraindication for immune therapy would be one of those issues. But things like performance status, um, uh, renal function, liver function, other considerations, I think enfortumab vedotin and pembrolizumab is as easy to give as platinum-based chemotherapy in this setting. Now, clearly, there are some patients who can't have systemic therapy, maybe really poor performance status, other considerations, and there may be an indication for single agent immune checkpoint inhibition in this setting. You'll be aware that pembrolizumab and to some extent atezolizumab are given as monotherapy, and they're obviously well tolerated. My personal experience of this has not been very positive. My personal experience is that those patients who we give single agent immune therapy to need to have very slow growing cancers because single agent immune therapy is not that great at getting in control of disease. Well, you'll be pleased to know that there are a number of treatments being investigated in the first line setting. There are actually 7 neoadjuvant, sort of adjuvant ongoing trials exploring platinum chemotherapy in the neoadjuvant setting with immune checkpoint inhibition. There are even neoadjuvant triplets, durva, tremi, and enfortumab vedotin. Incredibly exciting, in my opinion. We're looking at circulating tumor DNA in INVIGOR-11. There are other maintenance trials that are ongoing. We'll have to see how they pan out. I think it's going to be hard for them to supersede EV Pembro, in my opinion. And then, of course, we've got a second generation of antibody drug conjugates coming through, disitamab vedotin, sacituzumab govitecan. Incredibly exciting time in urothelial cancer. Oh, hello, I'm Tom Powles. I'm an oncologist from London. I'm the director of Barts Cancer Centre. I treat patients with urothelial and kidney cancer. This is a good question because the ESMO and NCCN guidelines have both been updated relatively recently. And I'm going to start by just talking about those patients whose cancers have progressed after platinum-based chemotherapy and maintenance of avelumab. Um, the reason I'm starting there is because that's where most of our data lies, but I am going to talk about the EV space after that, if I may. So essentially, for those patients whose cancers have progressed after chemotherapy and immune checkpoint inhibition, historically, what we've been giving patients is single agent antibody drug conjugates, particularly enfortumab vedotin. And the reason why we've been using that drug is it has level 1A evidence in EV 301. It's an active agent, 40% response rate, a 30% reduction in the risk of death. So that drug, though, has now moved to the first line space, which is complicating things a little bit. Other options in this space, clearly for those patients who have FGFR alterations, erdafitinib is an attractive agent. Again, it has about 40% response rates PFS of about 6 months. And then there are other ADCs, such as sacituzumab govitecan, with single agent data, which are coming through at the moment. And then most recently, drugs like TDXD, the HER2 ADC, which was approved by the FDA in the context of a basket study with only 16 bladder cancer patients. So quite a lot of choice there. And then, of course, there's also second line chemotherapy, which we've used historically. The second space, which is more complicated, is for those patients that have had EV Pembro and their cancers have progressed. And essentially, what we're recommending is we switch patients to platinum based chemotherapy again, or if they have FGFR alterations, erdafitinib. So the data for the treatment of second-line therapy for patients whose cancers have progressed after first-line chemotherapy and immune checkpoint inhibition is based around really a series of studies, one of which is the Thor study, which looks at patients whose cancers have FGFR alterations. The Thor study had two cohorts, those patients who previously received chemotherapy and immune therapy and randomization against basically a Taxol or more chemotherapy. And that was a positive study for OS with a hazard ratio of 0.64. And that makes erdafitinib a standard of care for those patients whose cancer progressed after chemotherapy and immune therapy. The story's not completely straightforward because erdafitinib didn't beat pembrolizumab in patients whose cancers had progressed after chemotherapy but were immune therapy naive. This underlines the importance of immune checkpoint inhibition early in advanced urothelial cancer and underpins this issue about giving immune therapy first line, particularly EV Pembro looks attractive in that space. The other options I talked about for those patients that didn't get first line EV Pembro, got chemotherapy and immune therapy, enfortumab vedotin is a standard of care and should be sequenced quickly, in my opinion. And then other options such as sacituzumab, TDXD, and more chemotherapy have less strong evidence. They don't have level 1 evidence at the moment. So when one selects second line therapy, one needs to think carefully about what patients have had previously. If they've had platinum-based chemotherapy and immune checkpoint inhibition, then the next standard treatment would be enfortumab vedotin, or potentially erdafitinib in FGF-altered patients. If they had EV Pembro in the frontline space, then the next option should be to give platinum-based chemotherapy. And then, of course, there are a third group of patients that got first-line chemotherapy, didn't get maintenance avelumab, and then obviously second-line immune checkpoint inhibition would have a role to play in that space. So it has become quite complicated with those three groups of patients I just described. The next key issue in selecting patients, in my opinion, would be around FGFR alterations. Patients who have FGFR alterations have the additional option of erdafitinib. And then I guess the third issue, which is really important, is what's the patient's condition like? What are their comorbidities? How many side effects do they have from first-line chemotherapy? And how would we select therapy based off that? The reality is all of our drugs, unfortunately, have a significant toxicity profile, particularly the ADCs, the chemotherapies, and the FGFR inhibitors, maybe less so for drugs like pembrolizumab. But pembrolizumab, as a single agent second line therapy, is not great at getting control of disease. So I think this second line space remains challenging, which is why I firmly believe picking the first line therapy, giving the best drugs we can up front, is really important for our patients. There have been some updated data looking at this is the second line setting, looking at both the ADCs, sacituzumab govitecan, within the context of not just the trophy trial, but some real world data, but also updated data from EV301, the randomized phase 3 study, which was published relatively recently, which shows consistent response rates, consistent overall survival benefit associated with unfortunate vedotin. So we're seeing more data, more robust data. And actually, I think what we're also seeing is more experience at managing the toxicity, particularly with unfortunate vedotin. There were some issues initially around some skin toxicity, which occurs early, peripheral neuropathy, which occurs late. I think we've got better at dose interruptions and dose reductions associated with those two. Regarding the immune checkpoint inhibitors, well, they've been around for about a decade now in urothelial cancer. I think pembrolizumab, based off Keynote 45, remains the sort of go-to second-line drug. But as I said previously, I'd like most patients to get first-line immune therapy, either in the context of EV Pembro, Gemcis Nivo, or maintenance of avelumab. So second-line immune therapy hasn't been generating that much data recently, but again, there is some retrospective analysis of some of these trials showing durable benefit. And indeed, you could argue the Thor study in cohort 2, which had the pembrolizumab arm in it, underlined the activity associated with pembrolizumab in this space. New drug development in urothelial cancer is really important. The reason why is, I'm afraid, it's still the case, even with EV Pembro, that the majority of patients with advanced disease will ultimately succumb to their disease. Uh, Therefore, we do need to develop new combinations, but also new drugs. Bispecifics are exciting. I think some of the T-cell engagers are exciting. There are some new monoclonal antibodies, LAG3 and TIGIT, that are being explored. Uh, there's also other types of drugs which I think are, in my opinion, very exciting. And there's a new plethora of antibody drug conjugates, some targeting Nectin-4, some targeting HER2, dare I say it, HER3 as well. So we are getting new drugs in this disease. Also, there's some new combination data. There was some data on unfortunate vedotin and sacituzumab govitecan in combination in heavily pretreated patients, which looked exciting. So not only is the neoadjuvant area really exciting, but the new drug development area is exciting too, in my opinion. Oh, hello, I'm Tom Powles. I'm an oncologist from London. I'm the director of Bart's Cancer Centre. I treat patients with urothelial and kidney cancer. Okay, this is important because enfortumab vedotin and pembrolizumab is not given in a fixed number of cycles. It's given essentially until progression, and progression-free survival is 12 months, median progression-free survival. So some patients are on therapy for a year or more. So getting this right is perhaps, from an education and training perspective, the most important message. I think what I said previously is correct. I think enfortumab vedotin and pembrolizumab should be the go-to first-line therapy. I think it's transformative. My experience is patients go into long, durable remissions. The issue is how do we make sure we can give the drug safely, and how do we make sure we can give enough of the drug to induce these remissions? I think the adverse event profile of enfortumab vedotin and pembrolizumab, particularly at the beginning, is mainly driven by the enfortumab vedotin. It's associated with a rash in the first 3 cycles, which can be serious. If you see a patient the first 3 cycles with a rash, and it tends to be a rash which happens under the armpits, in the skin folds, can be on the feet as well. If you see that, one should hold the drug, and that's really important. If you treat through skin rash, particularly at the beginning, you can end up with issues like Stevens-Johnson syndrome, or even toxic epidermal necrosis, which has been reported. So cessation of therapy with skin rash, dose reduction, close monitoring is important. Steroid creams, other bits and pieces don't make a huge difference, to be honest. The second issue, which is important, is the neuropathy. So the neuropathy with pembrolizumab and enfortumab vedotin is driven again by the enfortumab vedotin. Pembrolizumab can be associated with nerve damage, but it's the enfortumab vedotin, which is really driving this, it's a sensory and a peripheral neuropathy. So it's not classic platinum-based neuropathy. You can get people who are unstable on their feet, in my experience. Asking patients to do up buttons is quite a good test. This tends to build after cycle 6, between 6 and 10, and it's a really common cause for dose reduction delays. My experience of this, again, is if you treat through peripheral neuropathy, you get into trouble quite quickly. So these two adverse events really require some attention. Of course, there's some fatigue, as you'd expect, and a bit of neutropenia, although I've not seen that as a problem. I've seen a little bit of transaminitis. And the final one is hyperglycemia. And hyperglycemia is actually quite an unusual side effect. You can see happening here infrequently. We don't really know enough about the cause of it, but it does seem to be associated with obviously hypoglycemia, diabetic ketoacidosis I've seen, and this requires careful monitoring of blood glucose, which I would recommend. It. Diabetic patients can take part in this first line combination. The reason why is they look after their diabetes well. I actually think it's those patients from a diabetic perspective are probably the safest because they know when they're getting hypoglycemic and know how to monitor their sugar. I think the chemotherapy, I'm not going to talk about the side effects of chemotherapy too much for obvious reasons today. I think chemotherapy essentially had higher rates of hematological toxicity. Uh, the main intervention from enfortumab vedotin and pembrolizumab toxicity is stop both drugs. If you think the immune therapy is driving it, and clearly things like hypothyroidism, colitis, other nephritis, transaminitis, all of these issues may be pembrolizumab related, and steroids should be administered under those circumstances. But my experience is steroids don't tend to reverse enfortumab vedotin and pembrolizumab toxicity. I think one of the challenges with immune checkpoint inhibition is not the chronic toxicity. We know they're well tolerated. The problem with them is the unpredictability and the potential severity of the toxicity. So what we see is particularly transaminitis, colitis, nephritis, and potentially pneumonitis. Now, some people say pneumonitis is more common with ADCs, but actually, enfortumab vedotin is not associated with high levels of pneumonitis. Uh, some of the other drugs, TDXD, other drugs, perhaps higher pneumonitis. The key to this, in my experience, is when you get this type of adverse event, is to give steroids and give them longer than you normally would imagine. So you need to wait till the adverse event has completely settled and then give another couple of weeks of tapered dose of steroids before stopping and potentially re-challenging the drug. And re-challenging with the drug is reasonable. And the adverse event does not always come back. Clearly, grade 3 or grade 4 adverse events, we tend not to re-challenge with immune checkpoint inhibition. The last piece is you might come to me and say, well, Tom, what about a grade 3 transaminitis after 6 cycles or sorry, 6 weeks of EVP? And that's tricky because it could just be the pembrolizumab, but actually it's more likely to be the combination of the two. Under those circumstances, I probably would start steroids, but I would also come down on the dose of enfortumab vedotin. So I do one dose reduction of that, I would re-challenge with both drugs. So I think what I'm saying is that there's a real art to giving immune checkpoint inhibition. I think we've got a lot better at that. There's an art to giving enfortumab vedotin, and we have a lot to learn regarding that. In my experience, it's no more difficult than chemotherapy. It's just different, and we need to be very vigilant for skin toxicity, peripheral neuropathy, and these positive interactions such as transaminitis, which could occur with both the immune checkpoint inhibitor and the ADC. I've talked already a bit about the adverse events, and what I wanted to talk about now is a little bit around what baseline tests we should be doing for these patients, and how we should monitor their adverse events moving forward. I don't think there are useful baseline tests for the skin toxicity or the peripheral neuropathy. And indeed, the skin reaction associated with immune checkpoint inhibition and other cancer drugs doesn't seem to overlap with enfortumab vedotin. Um, Nectin-4 is overexpressed in the skin. It's the target of EV. And a newer generation of antibody drug conjugates, such as disitamab vedotin, which target HER2, will have less skin toxicity in the future. Ocular toxicity, actually dry eyes is the commonest adverse event. We haven't routinely been performing ophthalmologic assessments in these patients. And ocular assessment is something which is, unlike some of the other drugs that we're developing, doesn't seem to be a major issue in my experience. Hyperglycemia, I think baseline glucose levels make sense. You might want to do a glycosylated hemoglobin. And then I think monitoring blood glucose during the first 3 or 4 cycles makes a lot of sense to me. Sacituzumab govitecan is a drug which I've not talked about in the same detail as enfortumab vedotin, but it is a drug which has accelerated approval in the US and randomized trials are awaited. It has a topoisomerase 1 payload compared to MMAE for enfortumab vedotin, and the toxicity is driven very much by that. Topoisomerase inhibitors are associated with diarrhea, and that is an issue with the drug. I've also seen fatigue, nausea, and vomiting. Um, and it's also worth noting that it's associated with hematological toxicity, as with chemotherapy. Neutropenia is the most concerning of that, and neutropenic sepsis is obviously a major issue in cancer medicine. In some of the trials we've been performing, we've been giving GCSF, which I think is reasonable, and many people are giving routine GCSF with sacituzumab govitecan. It's probably the commonest cause for dose reduction, along with fatigue, nausea, and vomiting and diarrhea. It requires careful attention. The FGFR inhibitor erdafitinib is actually quite a widely used drug in urothelial cancer because about 25% of patients have FGFR alterations with advanced disease. Many people say it's an oral drug and therefore it's easier to give, and that's not my experience. My experience is it's got quite a lot of toxicity in the same ballpark as sacituzumab and enfortumab vedotin. It's certainly associated with um, classic fatigue and anemia, but one of the unusual side effects is nail toxicity. The nail toxicity can be really troubling for patients and very painful. And I've seen patients' nails fall off if you get the dosing of this wrong. And so this is one of the common causes of dose reduction. The other area which I think is unusual is it can cause a central serous retinopathy. It can cause eye toxicity. And this does need careful monitoring. And we would be doing baseline ophthalmology examinations for these patients. Other adverse events, which are thought to be on target, such as hyperphosphatemia, are worth looking at, but actually we dose accelerate. We dose increase from 8 to 9 milligrams in the absence of hyperphosphatemia. I'm not doing so much of that myself at the moment. Having said that, I think that looking at the U&Es for this group of patients is really important. We've also seen some mucositis and some PPE with this drug. So as I said before, a great drug, but not better tolerated than other drugs available to us. Well, I've talked a little bit today about the spectrum of adverse events, from eye toxicity and nail toxicity to skin toxicity, neuropathy, neutropenia, vomiting, transaminitis, and nephritis. It's a huge spectrum of adverse events. I haven't talked about some of the rare adverse events, cardiac toxicity associated with immune checkpoint inhibition. And so the wider medical team is involved with these patients now. We're routinely referring patients for endocrinology review and cardiac review, dermatological review, but also the wider MDT looking at other healthcare professionals within our team, nursing support, foot care is really important, can be very important for these drugs. Nail toxicity, also relevant. So there's a wider group of healthcare professionals involved in managing the adverse events associated with these complex agents in advanced urothelial cancer.